So as in every system, remember, you have to review the anatomy and physiology. Anatomy and physiology will be with you in every test and will be with you in the PANS. Okay, in the PANS, there are questions that if you don't know anatomy and physiology, it's impossible to answer them. And I'm sure that in the period when you graduate, in the period of preparation for the PANS, you're not going to study anatomy and physiology. So you have to study it now. Okay, now is the moment to review again all of these details of anatomy and physiology. We're going to be covering the anatomy and the physiology. Okay, not as deeply as we did in the PMO. Okay, it's your responsibility now. You already know this stuff. And I'm going to tell you again how many chambers, how many valves the heart has, etc. You have to review it. Okay, EKG, probably you can teach me EKG now at this point because you already know a lot of stuff that many doctors don't know. I'm sure of that. When you rotate in Harvey, you're going to realize that I'm saying the truth. Okay, you're going to be like, oh, I know more than these people here. Okay, but we are going to focus on pathophysiology. We are going to study first heart failure. Okay, there are different types and different causes of heart failure. We are going to review what is pulmonary edema, which is a complication of heart failure. Okay, when some people have different dysfunctions in the heart is unable to pump the blood efficiently, is unable to supply the organs with blood. Sometimes, for different reasons, there is a crisis, a decompensation of this chronic condition, and we call that pulmonary edema or acutely decompensated heart failure. Okay, we are going to learn a lot of terminology. We are going to learn why things happen in our body. We are going to talk about some conduction disorders that you already know some of them from EKG. I've seen some of you studying, and I know what you're studying. So you already know these things. And we are going to talk about coronary artery disease. Okay, today we're not going to have time to cover all these, of course, but during this week, okay, and in the following days, we are going to be talking about these things. The circulatory system, okay, has to be seen as the system that distributes nutrients, okay, in our body. Okay, the system that distributes nutrients and also picks up a lot of bad stuff, a lot of waste products. Okay, we have many tissues with different needs, okay, and the blood vessels, the capillaries are the ones that carry nutrients to those tissues. You have to imagine the cells as factories. Remember, they are constantly working. Also, the cells store many of these nutrients. For example, glucose, fatty acids, proteins are stored inside the cells. Okay, some of the nutrients cannot be stored. For example, oxygen can be stored, so oxygen has to be supplied continuously, and CO2 has to be continuously removed. Remember the interaction of the circulatory system and the respiratory system in this task. There is a picture that I wanted to show you. Okay, it's this picture here that shows a red blood cell passing through a capillary. Okay, I've been looking for this picture a lot. I've been like several years probably looking for such a picture that shows, because I want you to have an idea of how the red blood cells actually squeeze against the capillary walls in order to exchange the CO2 and the oxygen. Okay, the red blood cells pass very fast through the aorta, through the arteries, very fast, very fast. When they get into the capillaries, they move at a speed that I remember is a third of a millimeter per second. Very, 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 very slowly in order to be able to give oxygen and pick up the CO2. Okay, but all of these processes that we studied during the PMO. The heart, we're not going to repeat the anatomy of the heart. I repeat, chambers, valves, layers of the walls, conduction system, all of these are things that you are tired of studying. Okay, you have to review, of course, in order so you don't forget something, but you have to review by yourselves. Let's remember something about the circulation. Okay, remember the two first branches of the ascending aorta are the coronary arteries. There is a right and a left coronary artery. Okay, The left coronary artery then branches into two important arteries, which are the left anterior descending, that supplies blood to the anterior and part of the lateral side of the heart, also to the superior and anterior part of the septum of the heart. And then we have the circumflex that turns around and supplies the lateral and posterior side of the heart, mainly in the left ventricle. The right coronary artery supplies the right ventricle and also the posterior and inferior wall of the septum of the heart. Very important also to remember that the atrioventricular node is supplied by a branch of the right coronary artery. Okay, why is important this? In 90% of the population, the right coronary artery supplies the AV node. These people are known as right dominant people. And in the other 10%, well, in the other 5%, the AV node is supplied by the left coronary artery. These people are called left dominant. And in the other 5%, that is a combination of supply of both arteries, okay, the left and the right coronary artery. So they have like an anastomosis in the AV node that facilitate the supply of blood to this node. Okay, so when you have an obstruction of the right coronary artery, in most people, what can be affected is, of course, the right ventricle and the AV node, producing several conduction disorders. What else? Well, there you have the conduction system for your independent study. Repeat. EKG, we are not going to repeat what these waves mean. You have had many tests, many quizzes, and you have studied these many times. There is the correlation of the waves of the EKG with the systole. Remember what they represent. And when you see any abnormality in these waves, what you expect to find in the heart, what part of the heart can be affected. Now we are going to enter into the circulatory system. Okay, you can study the circulatory system in different ways. And sometimes what we can do to understand better this anatomical and physiologic stuff is to compare it to things that we see in our daily life. Okay, we use models from the daily life in order to understand what happens in science. Okay, and a model that can be used is compare the circulatory system to an electrical power supply. There is a power plant that supplies electrical energy to different, for example, cities, okay, different industries, different houses, different buildings. All of them will have a different demand. Maybe there is a small house with people that save a lot of money and they only have a lamp. And there is a factory that demands a lot of energy. So, of course, you have to send a lot more energy to that factory than to that house. And that's what our circulatory system does in combination with the endocrine system and in combination with the central nervous system that is constantly controlling the amount of blood, in this case, that goes to different organs. The circulatory system, as this there says, the energy takers, the organs, are placed in parallel, okay, and they vary greatly in the amount of power consumed. If you compare the amount of power that, for example, the brain consumes with that of the liver or that of the stomach, there is a lot of difference. Of course, depending on when they are in what part of the day we are talking about. Okay, in the moment of digestion, of course, the stomach consumes a lot of energy. When the stomach is at rest, almost no energy, but the brain is constantly consuming the same amount of energy. Doesn't matter if we are sleeping or we are in a final test. The amount of energy that the brain consumes is always the same. It never stops working. So these organs are placed in parallel. What that means? This is the power plant, and there are different supplies that in parallel give energy to different organs. Okay? That allows that we can distribute the amount of power that they need exactly. Imagine what would happen if the organs were placed in series. Imagine this were the heart, and we had the organs placed one after the other. When this organ receives the oxygen and the nutrients, what is left for this? And then what is left for this and what is left for this? Only wastes. Okay, this is the objective of placing the organs in parallel rather than in series. Or imagine that there is a block here, an obstruction here. Nobody will receive any kind of supply. If there is an obstruction here, of course, this organ will suffer, but the rest of the organs can keep up with the metabolism, can keep up with the functions, and can continue with the process of life. The heart is the one that produces the power, okay? And of course, we have to regulate the heart, okay? And that's why, and that's the importance of the endocrine system and the nervous system, autonomic nervous system, controlling the heart. The current that the heart produces is what we call cardiac output, okay? You have to know how to calculate the cardiac output. You have to know what things contribute to increasing or decreasing the cardiac output. What happens in different situations with the cardiac output when we are, for example, standing, when we are lying down, when we are squatting, when we are doing different things. What happens with the cardiac output? We are going to be learning this stuff during pathophysiology, things that have to be clear in your minds. The cardiac output is calculated as stroke volume. Remember, stroke volume is the amount of blood that the left ventricle pumps per beat times the heart rate. Okay, we are going to do some calculations. Well, what happens if the circulation is in series? This happens. Okay, any kind of interruption, any kind of problem would affect the entire system. We're going to have two scenarios here, okay? Someone is resting at home. This can be any of you during these days, right? This is how you spend life nowadays, right? The heart rate is 60 per minute, stroke volume 70 per minute. We simply multiply these times these, and we obtain the cardiac output in liters per minute normally, 4.2 liters per minute. This is a very relaxing position. Let's compare this to another person missing the train, okay? If you are running very fast, because you are missing a train or something else, the heart rate will increase a lot. Let's say 185 beats per minute. The stroke volume will increase also, okay? Because the autonomic nervous system is releasing epinephrine into the circulation, contracting the veins, increasing the amount of blood that enters the heart, increasing what we call the venous return. By the Frank-Starling law, this left ventricle will dilate to receive all that blood and will contract more strongly, plus the action of epinephrine that increases the force of contraction. All of this increase in the cardiac output in the force of contraction will increase the heart rate and the stroke volume to give us a cardiac output of 22 liters per minute. Okay? This happens in the real life. Look how our heart is able to change from pumping 4 or 5 liters per minute to pumping 22 liters per minute in different situations. Okay? 5 times as much as some minutes earlier. Later we're going to go back to these scenarios. Okay? This is something that we explained or covered in the PMO. Notice how different organs or the flow of blood to different organs will change depending on if we are at rest, okay, or if we are under or doing exercise. Notice how the brain continues having exactly the same amount of blood supply because the metabolic activity of the brain doesn't change in different situations. What changes maybe is the area that is activated, but the total metabolism of the brain and the blood supply of the brain doesn't change. You're going to learn how when the organs change or increase their metabolism, also they increase the demand for blood and more blood goes to those organs. How that happens? For example, a muscle is at rest. There is a certain pH, there is a certain amount of oxygen and CO2 in that muscle. When we start working out that muscle, the pH decreases, there is CO2 produced, and this amount of CO2 and hydrogen dilates the blood vessels, and more blood goes to that muscle. The same happens to all of the organs. So organs start demanding blood, and our body starts diverting the blood supply to the organs that need the blood flow in that moment. When we are doing exercise, as you see here, the heart increases, the demand for oxygen is beating faster, Okay, notice the skeletal muscles go from 1.2 liters to 12.5 liters of blood. It's a very important demand of blood. Okay, the skin also receives more blood. Vasodilation, we need to eliminate all of this excessive heat that we are producing during exercise. The kidneys start receiving a bit less. Okay, other organs have priority, like the heart, the muscles, and the skin. Notice the abdominal organs from 1.5 liters to 600 milliliters, and other organs also receive less. So, depending on what we are doing, the level of our metabolism, the blood supply will change, and there has to be someone controlling this. Okay, there has to be someone controlling this. Different systems. Okay, there are local regulatory processes, and there are also systemic regulatory processes like the autonomic nervous system and the endocrine system. What is your question? No, that probably means that it's not a scale. If it was a scale, we would need a very large image there. Okay. Notice that when we are at rest, only 20% of the capillaries of the muscles are open. When we are exercising, 100% of them are open, vasodilation, leading to these changes or these hemodynamic changes. Well, how we regulate it? Well, the blood vessels cross-section, the diameter of the blood vessels, remember, vasodilation increases the blood supply to different organs. Cardiac activity, you can increase or decrease the cardiac activity by means of hormones or the impulses of the autonomic nervous system. Depending on acetylcholine, epinephrine, the cardiac activity will be faster or slower. The contraction will be weaker or stronger. And the amount of blood that is in the circulation. Okay, more blood means the ventricles will dilate to receive that blood. Remember when we stretch the walls of the ventricles by the Frank-Starling law, the ventricle will contract more strongly, increasing the cardiac output. So any increase in the venous return will represent an increase in the cardiac output. Okay, any decrease in the venous return will represent a decrease in the cardiac output. These are relationships that you have to have very clear. There is a diagram that shows different factors, how different factors affect the distribution of blood into different organs. Okay, we have in the upper part vasodilators, and in the lower part vasoconstrictors. In green, you have the intrinsic regulatory mechanisms. And in the blue part, to the right, you have the extrinsic mechanisms. Remember, you have local mechanisms that act at the level of the tissues, regulating locally every capillary bed. And we have systemic or extrinsic mechanisms. There you have different substances. For example, oxygen, CO2, hydrogen, potassium, prostaglandins, adenosine and nitric oxide, all of them will produce vasodilation, depending, of course, on how they are. If in any tissue we have low oxygen, okay, or high CO2, because the tissue is metabolically active, consuming oxygen and eliminating CO2, and decreasing the pH locally, acidosis locally, all of these factors increase potassium. The presence of prostaglandins, adenosine, or nitric oxide will produce vasodilation, attracting blood to that tissue. Think in a tissue that is metabolically active. Okay? Vasoconstrictors, any stretch in the blood vessels. Remember the regulation of locally of the blood vessels. If there is a lot of more blood going to certain area, that will produce a stretch in the blood vessels, and this will produce a reflex constriction, local mechanism. And also, there is a substance that is called endothelin. We are going to talk later about this again. Endothelin is a very powerful vasoconstrictor. In fact, it's the more powerful vasoconstrictor that exists. Okay, why we don't have continuously vasoconstriction? Because we have many more vasodilators than vasoconstrictors. There is a balance locally at the tissues. Okay, so the tissues maintain the amount of blood that they need in every moment. Extrinsically, we have to remember the sympathetic nervous system. Okay, a decreasing in the sympathetic tone will produce a vasodilation, while an increase in the sympathetic tone will produce a vasoconstriction. The hormone atrial natriuretic peptide, ANP, will produce vasodilation. The hormone antidiuretic will produce vasoconstriction. Remember, another name for antidiuretic is vasopressin constriction. Angiotensin II will also produce vasoconstriction. Notice the name angio means blood vessel, tensin, constriction. Okay, so different factors, epinephrine, norepinephrine, the catecholamines will also produce vasoconstriction. Okay? These hormones, angiotensin II and antidiuretic, normally they have other actions as well. Okay? Remember, antidiuretic retains water, free water. Okay? Angiotensin participates in many different other actions that we are going to mention later. They have a vasoconstrictive effect only at very high doses, means during real emergencies. Okay, when at normal physiologic concentrations, ADH and angiotensin II don't have too much vasoconstrictor effect. If we are in a real emergency, we are bleeding, is when they are released in more amounts and they start having this vasoconstrictive effect. Let's remember something about the capillaries. There are different types of blood vessels. Arteries, arterioles. Remember, they branch, producing capillaries. Capillaries are the actual blood vessels in where the exchange of gases and nutrients occur. There are different types of capillaries. In the nervous system, for example, we have very tight capillaries that we call continuous capillaries. Okay? Then we have some other capillaries that are more leaky. For example, in the liver, in the spleen, in the bone marrow, we have discontinuous capillaries or sinusoids. And in between, we have the fenestrated capillaries. We have the examples in the kidneys that have like little holes to allow certain substances to be eliminated or reabsorbed in the process of urine formation. Okay, the capillaries are really, really very small. Okay, notice, remember from the picture we showed before how red blood cells have to squeeze in order to pass through these capillaries one at a time. Okay, very, very small capillaries. Normally, the capillaries have only a layer of endothelial cells surrounded by a basement membrane, and they don't have a smooth muscle around them. It's a very thin layer. And we have to talk about a specific tissue, that is the endothelium. That is the tissue that lines the capillaries. And it's important to understand these concepts because they form the pathophysiologic basis of many, many of the diseases that we are going to study in cardiovascular pathophysiology. For example, we are going to study atherosclerosis. We are going to study vasculitis. We are going to study some diseases that have to do with the local disorder of the endothelial cells. We are going to study some coagulation disorders that have to do with a malfunctioning or a disorder in the endothelial cells. We have to understand how the endothelium is like a pavement that is very smooth. Okay, if we are walking in a smooth pavement, if we are walking, for example, in this floor, we don't have any problem. If there are some tiles missing, we are going to have troubles walking here. Okay, imagine the same happening in the blood vessels. Okay, all of these cells are very smooth. Okay, when the endothelial cells are in a state that we call the resting state, they form a very smooth surface that doesn't allow any red blood cell or white blood cell or platelet to adhere or to attach to these walls. Okay, it's a very slippery surface that allows a very smooth circulation without any kind of turbulence. The endothelial cells, they have what is called a glycocalyx. I'm going to show you a picture later. This glycocalyx has some substances, glycoproteins and proteoglycans. These substances bind a huge amount of water forming a gel layer, okay? That is a very slippery layer in which the cells and the platelets are constantly like shooting along this slippery surface. They never get attached to these endothelial cells. It's like a viscose gel, okay, that prevents mechanical injury, okay, prevents any kind of adherence of the platelets, for example. This resting endothelium also has many negative charges. Okay, these glycoproteins, these proteoglycans have negative charges that repel the negative charges of the cells, red blood cells, white blood cells, and platelets. Okay, and they have an enzyme that is called the cyclooxygenase that produces prostacyclin. Prostacyclin also is known as prostaglandin, one of the prostaglandins. This prostacyclin inhibits platelet aggregation and produces vasodilation, relaxes the vascular smooth muscle cell. Okay, it's important to understand how the endothelial cells are when they are at rest. They are at rest means there is no inflammation. We are going to compare resting endothelium with the activated endothelium later. In this picture, you are going to see how these endothelial cells look under an electronic microscope. Okay, these are like hairs, right? Imagine in the bottom of the sea or the bottom of a river, you have like algae or this slippery material that is sometimes difficult to walk, to step on it. Okay, these are endothelial cells here. This is the basement membrane. Here is the glycocalyx. Okay, this is another type of view. You can see the endothelial cells, the tight junctions between the endothelial cells. Notice this that looks like grass on top. Okay, that is the glycocalyx. And this is a representation. It's a diagram that shows the glycocalyx. Notice the height of the fibers of the glycocalyx. And notice that in between the glycocalyx, there are other substances that appear in blue. These are called the adhesion receptors and are receptors that fit some proteins that are present in, for example, white blood cells and platelets. Okay? This glycocalyx is preventing an interaction between these receptors and some other receptors that are present in some cells that can be white blood cells, platelets, or, as in this case, a CTC, that means circulating tumor cell. Okay? So, what is the meaning of this? To understand it, we have to go down here to understand what happens when there is inflammation in endothelial cells. When there is inflammation, for example, some cells are producing metalloproteinases. There is what we call shear stress. Shear stress is a stress that occurs because of the very fast circulation of the blood. Any activation of the endothelium because of inflammation or other type of stress will produce what is called a shedding of the glycocalyx. All of these fibers will start going away, shedding of the glycocalyx. And this will let exposed the receptors, the adhesion receptors. These receptors will bind neutrophils, white blood cells of other types, platelets, and also can bind circulating tumor cells if someone has any kind of tumor cell circulating in the body. What that has to tell you is that inflammation, any kind of inflammation in endothelial cells can lead to a localized area of damage that allows, in normal cases, the adhesion, diapedesis, and migration of the neutrophils, as in the normal physiologic inflammatory response, but in other cases will lead to a chronic inflammation, will lead to the formation of atheroma, atherosclerosis plaques, or will lead to the attachment of tumor cells and facilitation of the metastasis in different organs. Okay, so understand, please, the role that inflammation has in the development and in the chronicity of some diseases. Yes? There are different types of, let's say this is an endothelial cell, okay? There are different types of adhesion receptors, okay? They are in vesicles inside the cytoplasm of these cells, okay? Imagine this is the glycocalyx, okay? Depending on the type of inflammation, the cell is gonna present outside different types of adhesion receptors. Some of them are called, for example, von Willebrand factor, will attract platelets. Other receptors are called P-selectin. These will attract neutrophils. Other receptors, there are hundreds of these receptors that will match other cells. Can be viruses, or can be circulating tumor cells. So depending on the type of inflammation, depending on the type of mediators that are acting locally, the cells will release one or other of these adhesion receptors. This is a generic name, okay? But the important thing is, if the glycocalyx is present, doesn't matter how many receptors you have there, they're not gonna fit. There is not gonna be an interaction between the cell and the receptor, because remember, this glycocalyx has negative charges and has a lot of water, forming like a gel layer there. If inflammation produces the shedding, this is very important, inflammation produces the shedding of the glycocalyx, then the interaction will be possible, okay, between the tumor cells, or the bacterial cells, or the neutrophils, or the macrophages, or any kind of cell. Does that answer your question? So the activated endothelium, of course, this thing here is not for memorization, okay, just for you to see how they represent this process, okay, of adhesion of the cells and migration of the inflammatory cells under the endothelium, okay. Here we have the endothelium. This is the resting endothelium, and here we have the activated endothelium exposing all of these receptors, okay. And here we have how these receptors interact with cells, inflammatory cells. This is a leukocyte. Notice how there is an interaction between the receptors of the endothelial cells and the receptors of the leukocyte. The endothelial cells like grab the leukocyte and allow the migration of the leukocyte by diapedesis. Okay, these are things that some years ago were studied, like neutrophils adhere, roll, move by diapedesis, and migrate to the site of infection. That was the only thing we knew. Nowadays, there are so many proteins and so many receptors and interactions involved that these things has become really, really, really complicated, okay? The knowledge that we have about these things is increasing exponentially every day, okay? I remember I read recently a book that was written in 1960-something about pathophysiology of the immune system. And the book, I will try to find it and make a picture. The book said, lymphocytes are there like spectators. There was an inflammatory reaction. The writer was describing the inflammatory reaction, and he wrote, neutrophils, macrophages are phagocytosing bacteria, blah, 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 blah. And lymphocytes are like spectators. We don't know what they are doing there. Now we know what they are doing there. Antigen-presenting cells, cytokines, interleukins, memory cells, all of these things that we know nowadays. But 1960-something, they were spectators of the inflammatory response, just looking at what is happening there. Okay, now these endothelial cells produce several products. Okay, nitric oxide, for example, remember, is a vasodilator. Okay, we have to know, or we know several things about nitric oxide we didn't know several years ago. Nitric oxide is produced by an enzyme that is called the eNOS, okay, nitric oxide synthase. And you have to know something. This enzyme in smokers And in people with diabetes, instead of producing nitric oxide, produces superoxide radicals, free radicals. Okay? And you already studied what is the effect that free radicals produce on the tissues. Imagine an enzyme that normally is there to maintain the vasodilation when necessary, now is producing free radicals that will damage the endothelial cells. So if you go back, how you go back here? If you go back here, you will understand why people who smoke or people with diabetes are so predisposed to microvascular damage in different organs of the body, in the retina, in the kidneys, in the brain, in the heart, and in different places. So another important thing to remember about this nitric oxide, that there are medications, for example, nitroglycerin, organic nitrates that we can use, and they release nitric oxide very fast directly into the tissues, resulting in immediate vasodilation. Okay, we are going to study, when we study, we have to try to find always the relationship with treatment, with pharmacology. Okay, once you understand the basis, the pharmacologic basis of the treatment, you don't need to start memorizing again stuff. Okay, nitric oxide is a vasodilator. We give nitroglycerin, it is going to release nitric oxide into the different arteries and will produce immediate vasodilation. The endothelial cells also produce angiotensin converting enzyme, not everywhere, mainly in the lungs and in the glomerulus. Okay, this is the one that we inhibit when we want to treat hypertension. Remember, angiotensin converting enzyme is the enzyme that converts angiotensin I into angiotensin II. We are going to talk later about angiotensin II. And they produce endothelin. We mentioned this before as the most powerful vasoconstrictor that exists, that we know. Okay, there is a medication that you are going to study also. I don't know if you already studied this. It's called bosentan. Bosentan is an endothelin antagonist. So we produce a vasoconstrictor, and we have a medication that inhibits this vasoconstrictor, bosentan. This is used to treat pulmonary arterial hypertension. Okay, sometimes studying the correlation between drugs and physiologic stuff allows or helps to remember better these things. Well, remember this heart, the diameter of the blood vessels, the amount of blood in the circulation has to be very closely regulated, okay, very closely regulated. So the autonomic nervous system is in charge of a very important part of that regulation. Remember, the sympathetic nervous system normally produces vasoconstriction, epinephrine, norepinephrine. Vasoconstriction will occur everywhere except in the central nervous system. We don't need vasoconstriction in the brain. We need always the brain to receive the same amount of blood. And the heart also has to receive more blood when the sympathetic nervous system is activated. The sympathetic action limits the vasodilation in skeletal muscle in order to maintain the blood pressure, and allows more vasodilation in those muscles that are presently most active. What that means? Imagine someone is working out and is doing biceps. Okay, he's only using the biceps. He's not doing anything in the legs or in the abdomen or in the back. The sympathetic nervous system will produce vasoconstriction everywhere except in the brain and in the heart, and will limit or will allow more vasodilation, will not allow vasoconstriction in the muscles that are working. Nobody's very clear about why this happens. Okay, they haven't found the relationship between high levels of epinephrine and vasodilation in the exercising muscle. Looks like there is a special mechanism that nobody has very clear, and they explain it exactly as I put it there. Okay, allowing more vasodilation, so it's respecting the vasodilation in the muscles that are most active. Remember, in that tissue, there will be less oxygen, more CO2, more hydrogen, more potassium, more ADP, more prostaglandins that will produce this vasodilation, and all of these factors oppose the effect of the sympathetic nervous system that is trying to produce constriction at this point. The sympathetic nervous system also increases the heart rate, increases the frequency of depolarization of the sinoatrial node. Okay? There are receptors that we call beta-1 receptors, okay, that are the receptors that the myocytes have that respond to the action of epinephrine, increasing the frequency of the depolarization and thereby the heart rate. Well, there is some terminology here that you need to know. What happens in the heart under the effect of epinephrine and under the activation of the sympathetic nervous system? Notice that the first three are the most important, okay, bold letters. The sympathetic nervous system has a positive chrono, that means time, chronotropic effect, increasing the heart rate, positive inotropic effect, the force of contraction, and also increases the velocity of the conduction. That is called a positive dromotropic effect. Do I need to know that? Well, when I was preparing this, the first two were the only one in bold letters. But then I started reviewing Kaplan for the PANS preparation, and the dromotropic effect appears. So you have to know what is dromotropic effect. Increase in the velocity of conduction. The other two, bathmotropic, lusitropic. I have to be sincere, it's the first time that I see these terms. Bathmotropic, lusitropic. Okay. That's okay. But if you want to know it, it's better. The more you know, the better. Well, now let's go back to the first two scenarios that we saw, the relaxed guy in the scenario 1 and the other guy that lost the train in the scenario 2. What happened in those scenarios? Well, the sympathetic nervous system, sympathetic tonus was low. Remember, when we are at rest, most of the time, the one that is active is the parasympathetic nervous system. We are supposed to have this activated all of the time, okay? The parasympathetic activity being high slows the heart rate, releasing acetylcholine, okay, via the vagus nerve. In the scenario 2, what happens is activation of the sympathetic nervous system, release of norepinephrine, okay, in the postganglionic cells, release of epinephrine from the adrenal gland into the circulation will produce panting heavily, because running has dramatically increased the muscles and heart's consumption of oxygen and production of CO2 and lactate. Okay, the sympathetic, remember, also activates the beta-2 receptors in the lungs, producing bronchodilation. Okay, the smooth muscle cells in the gut, the bladder, and in the uterus will relax via the beta-2 stimulation. All of these things will happen in the body. Remember, you have to know the actions of the sympathetic and parasympathetic nervous system, not only on the heart and in the circulation, on everywhere. Okay, how sympathetic activity prepares us for the fight or flight response, and the parasympathetic for all of the other activities, normal activities during the day. These are other actions of the sympathetic nervous system. Remember, not only the muscles need oxygen, that's why we increase the respiration and the circulation, they need also glucose and other nutrients. That's why the sympathetic nervous system starts breaking down glycogen in the liver to release glucose into the circulation, increases gluconeogenesis, the formation of new glucose in the liver and in the kidneys from amino acids, from fatty acids. All of this is done by the action of epinephrine on beta-2 receptors on those cells. Also, we increase the breakdown of lipids, lipolysis. The adipose tissue has beta-3 receptors. Okay, these beta-3 receptors will stimulate lipolysis, another type of fuel. Also increases the production of heat. Stimulation of beta-3 receptors increases thermogenesis, okay, in certain type of adipose tissue, brown or beige adipose tissue. And renin is released from the kidneys because of a stimulation of the beta-1 receptors. Okay? We are going to study how the kidneys have different forms of releasing renin. When there is a drop in blood pressure, okay, the kidneys will fill. Remember, we have structures, the juxtaglomerular cells, that the juxtaglomerular apparatus will fill the drop in blood pressure and locally will stimulate the production of renin. But if for any reason our kidneys are not producing enough renin, we have stimulation from the autonomic nervous system, okay, epinephrine, that will stimulate beta-1 receptors and stimulate the production of renin in the kidneys. Okay, we also have to regulate how much blood is circulating, okay, the amount of blood. And we have several mechanisms. For example, antidiuretic hormone. Remember one thing that is very important, antidiuretic only retains free water. It's very important to have that clear. Okay, I sometimes receive emails from students, seniors, students. Professor, I don't remember the mechanism of this, why this happens. Remember, ADH promotes only free water reabsorption. Aldosterone will retain sodium and water will follow. Okay, that is a very important thing. The thirst mechanism is another way that we have to increase the amount of circulating volume. Okay, hormones retain water. We drink water because we feel thirsty. Okay, different mechanisms. The production of proteins. The more proteins we have in the circulation, the more water will be in the blood. Remember, these proteins form or establish what is called the oncotic pressure of the blood. If someone has hypoproteinemia, the fluid will escape from the vascular compartment into the interstitial compartment, producing edema. So making more proteins will attract more water. There are natriuretic peptides, A and P, B and P. Atrial natriuretic peptide produced by the atrial cells, B and P by the ventricular cells. Natriuretic peptides will eliminate sodium and water will follow. Remember, natriuresis is diuresis, elimination. Okay? Natriuretic peptides oppose the action of the renin-angiotensin-aldosterone system. They oppose these actions. They eliminate the amount of circulating volume. Every time there is a fluid overload on the heart, stretching of the heart walls will produce the secretion of natriuretic peptides. And the renin-angiotensin-aldosterone system, which is probably one of the more complex and more important mechanisms regulating the blood pressure. Let's have a 10 minutes break to go to the renin-angiotensin-aldosterone system. Okay, let's continue. We have to discuss something that is not new for you. That is the renin-angiotensin-aldosterone system. This is a very complex system in which several organs and systems participate. Okay, I have highlighted in red different receptors that we have in the body that are monitoring the blood pressure. We have baroreceptors in the aortic arch and baroreceptors in the carotid arteries. We have the juxtaglomerular cells in every glomerulus. Okay, remember, more than 1 million glomeruli per kidney. And also we have in the level of the nephron, the macula densa in the distal tubule. These three receptors are monitoring the blood pressure. Every time there is a drop in blood pressure, there will be a drop in the baroreceptor firing, okay, to the brain. This low amount of signals will represent or will stimulate an increase in the sympathetic stimulation, adrenergic stimulation, that will, of course, produce all of the effects of the sympathetic nervous system in the whole body and will activate the production of renin in the kidneys. Okay, normally the kidneys will produce a little bit of renin. And if the drop in blood pressure is very small, with that will be okay. You don't need to activate anything else. Okay, that happens, for example, when we are lying down and we stand up in the morning. There is a drop in blood pressure that is felt by the carotid receptors. They start releasing epinephrine a little bit, stimulates renin, and we increase the blood pressure, and that's okay. We don't need to activate anything else. Sometimes there is low amount of blood entering into the kidneys. That means we are dehydrated, or we are bleeding, or we have any other problem that will produce a decrease in blood pressure in the afferent arterioles. You don't necessarily have to have low blood pressure systemically. There can be a constriction in the renal artery or atherosclerosis in the renal artery and low blood flow into the kidneys. Locally, there will be a signal with low blood pressure in the afferent arteriole that will be felt by the juxtaglomerular cells, and they will start producing renin. Also, when there is low amount of salt, there is low amount of sodium chloride entering into the distal tubule, that will be felt by the macula densa. They feel exactly the amount of chlorine or chloride present. Okay, if there is low chloride, that means there is low sodium chloride. Okay, so that will produce, or this indicates for the kidney that there is a deficit in salt, so we need to start retrieving salt. So the kidneys will produce renin to activate aldosterone, and aldosterone start retaining salt. Remember, salt nowadays is very cheap and very abundant, but many, many centuries ago, salt was not abundant at all. Even salt was used as a salary for people. The word salary, in Latin, salt is sal. Salary comes from that word, from salt. Salt was given as a salary to the soldiers. When you fight for me in the war, I give you salt, so you remain alive. Yeah, it's very important to keep the amount of salt in the body. You didn't know that?
No,
yeah.
I didn't know.
Conservation of the food, but also to be alive. Okay, it's not. It wasn't abundant as you see today. Google salt as salary, so you'll find these histories about this thing. Yeah.
So renin would also do activate angiotensin and then higher blood
Yeah.
pressure, but it would also do aldosterone to activate salt.
To increase the salt retention, we are going to go now to this part, okay? And we are going to study the different effects of the renin, angiotensin, aldosterone system. This slide, you have had this slide many times. Dehydration, sodium deficiency, hemorrhage, anything that decreases the blood volume and decreases the blood pressure will stimulate the juxtaglomerular cells, macula densa, baroreceptors, and the production of renin will be increased. Remember, renin activates angiotensinogen, which is a protein made by the liver. Angiotensinogen is inactive, but is activated to angiotensin I. Angiotensin I in the lungs is converted to angiotensin II by the angiotensin converting enzyme. What happens with angiotensin II? We are going to explain later all of the actions of angiotensin II, but it normally produces vasoconstriction. Vasoconstriction increases the blood pressure. It stimulates the production of aldosterone. Aldosterone retains salt and water, increasing the blood pressure. It goes to the hypothalamus to stimulate the production of antidiuretic hormone. It gives us a thirst sensation, so we drink water. Okay, all of these are different actions of angiotensin II. There you have the actions summarized. Angiotensin II stimulates aldosterone, sodium reabsorption, generates the sensation of thirst in the hypothalamus, thirst center, okay? Releases antidiuretic hormone, increases the production of catecholamines in the adrenal medulla, epinephrine, to produce more vasoconstriction, increases the tonus of the arterial blood, vasoconstriction. That asterisk, later we are going to have the explanation of this only in emergency, real emergencies, and acts as a growth factor. This is probably new for some of you. Angiotensin II acts as a growth factor, stimulating the growth of the myocardial cells. So someone who has chronically elevated angiotensin II will develop cardiac hypertrophy. That's one of the mechanisms that explains the hypertrophy that occurs in the heart of people with chronic hypertension. There are going to be two. The heart is pumping against resistance. Constricted blood vessels, this increased force of contraction chronically will lead to hypertrophy of the muscles. The same thing that happens in the skeletal muscle when we work out. Muscles hypertrophy. The heart hypertrophies because of the hard work and because of the action of angiotensin II as a growth factor. So giving angiotensin converting enzyme inhibitors will prevent the hypertrophy of the heart. Because if we let the heart hypertrophy, there will be a moment when the heart is not going to be able to receive blood because it has a very small cavity. And people will develop heart failure as a result. Antidiuretic hormone is released when there is enough sodium but little water. What that means? Hypernatremia. Okay? We have more concentration of sodium than the physiologic one. The hypothalamus feels hypernatremia, I need to add water to the system. Okay? When there is simply dehydration, we are going to reabsorb sodium and water by the action of aldosterone. When we lose only water and have more sodium than water, now we are going to release antidiuretic hormone. Okay? It's released from the pituitary when the osmolarity of the plasma exceeds 280 milliosmoles, hyperosmolarity. Remember, this causes the insertion of aquaporins in the collecting ducts. Normally, the aquaporins are inside in the cytoplasm. Antidiuretic will make the insertion of these aquaporins in the cell membranes to increase the free water reabsorption. Okay, this doesn't reabsorb sodium. The vasopressor effects of ADH and angiotensin is only seen at very high doses during bleeding, hemorrhage. When we have a sudden decrease in blood pressure because of an important bleeding is when we see an enormous amount of ADH and an enormous amount of angiotensin II released in order to produce vasoconstriction. Of course, together with the epinephrine, etc. And here we have something that we covered during the PMO. Okay? That is very important to understand the regulation of the pressure and the volume of blood in the heart and in the whole circulatory system. Pressure-volume relationship. Remember, the heart has to be closely regulated. The amount of blood that the heart pumps every minute and every time has to be closely regulated. And this is done mainly by regulating the cardiac output. Okay, there are two ways of increasing the cardiac output. Okay, by increasing the preload. Remember, the preload is the stretching of the heart fibers before contraction. And you do this by increasing the amount of blood going into the heart. So, for example, if you squeeze the veins, more blood will go into the heart will dilate more and will pump more strongly. We'll have a very high volume before the diastole, before the systole, okay, or at the end of the diastole, and then we'll contract more strongly, having a higher stroke volume. Let me show you these. This diagram that you remember, probably from the PMO. Remember, there you have here volume and here pressure. There is something that looks like this. All of this here is systole. Systole starts here and ends here. And all of this is diastole. Okay? This is the end of the diastole. This is here the end of the systole. So what we have here is the end systolic volume. And what we have here is the end diastolic volume. Okay, in this diagram. If we subtract the end systolic volume from the end diastolic volume, we obtain what is called the stroke volume. Okay, remember this diagram from the PMO? Okay, there is a video that you're going to watch at home to remember all of these concepts. Okay, what I have represented, or the image that I looked on the internet is the relationship between these volumes when we are at rest. Notice the end diastolic volume and the end systolic volume, and during exercise. Notice how during exercise, the stroke volume increases very importantly. Remember the differences between the scenario 1 and the scenario 2, someone at rest, someone during exercise. Why this occurs? Why this increase in end diastolic volume and in a stroke volume occurs during exercise? Because of the action of the sympathetic nervous system. Epinephrine released into the circulation, squeezing the veins of the body, will send more blood into the heart. The heart will receive more blood and will contract more strongly. More higher end diastolic volume, stronger contraction with a smaller end systolic volume. Compare the end systolic volume during rest and during exercise. So receives more blood and pumps a lot more proportion of that blood. So the stroke volume during exercise will be a lot higher than at rest. That's why we are able to pump 20 liters per minute during exercise, because we have a lot more stroke volume and a faster heart rate because of the action of epinephrine on the sinoatrial node. Okay, these are concepts that are important to have in mind. Let's go back to here. We increase the cardiac output by increasing the preload, returning more blood to the heart, Frank Starling law, stronger contractility. There is a higher preload, squeezing more blood into the ventricle, higher contractility, more blood during systole, okay, higher stroke volume. Sympathetic nervous system, remember, increases stroke volume by increasing the heart rate, contributing to this difference in cardiac output at rest and during exercise. Video, very good video that explains all of these concepts of volumes and pressures during exercise and rest. If we represent the rest here, okay, you're going to see how you have like a slope. And you see this slope here? That is more steep during exercise than at rest. This slope represents inotropy. Inotropy. Remember the force of contraction. Okay, during exercise, because of the action of epinephrine, there is a higher inotropism. Okay, stronger contraction. So when you study these concepts, okay, how these pressure volume curve or diagram changes, remember the importance of inotropy by the action of epinephrine. I think I'm forgetting something. We are going to see how this changes when people have heart failure. Okay, we are going to study different types of heart failure. One is called systolic heart failure, and the other is called diastolic heart failure. And we are going to see how this pressure volume curve, these values of end diastolic volume and end systolic volume change when we have either systolic dysfunction or diastolic dysfunction. Okay, so please study this video carefully. Try to understand the meaning of these things. But what is more important is to remember that at this point, we have the end diastolic volume. At this point, we have the end systolic volume. That's the volume of blood that remains in the heart at the end of the systole. Okay? If we subtract these two, we're going to have the stroke volume. Okay? This minus this gives end diastolic volume minus end systolic volume gives the stroke volume. And today we have to start studying heart failure. Heart failure. The heart fails to do what? To pump enough blood to the organs. Okay? So there are different degrees. Okay? Some people don't even realize they have heart failure because they never move. Some people realize they have certain degree of heart failure when they start working out. I decide to go to a gym now. What is the first thing I have to do? Oh, go to the treadmill and run. I start running, and 2 minutes later, I have shortness of breath, a very important shortness of breath, and I start looking like blue. What's this? My heart isn't able to cope with the new situation. It was okay because I was watching TV and moving only one finger. And maybe, can you bring me water? That's the exercise. Oh, I have to ask for water again. Sometimes we wish people had telepathy, right? Doesn't realize that I have thirst. No, sometimes. So the heart is unable to generate a cardiac output that is enough to meet the needs of the body. Well, it depends on the needs. Okay, it depends on the needs of the body. There are different degrees. Cardiac output can be affected depending on what part of the heart is affected. One or the other ventricle will be affected. Normally, the first ventricle that gets affected is the left ventricle, okay? Producing a left-sided heart failure that will compromise the circulation in the dependent areas of that left ventricle. Which are the dependent areas of the left ventricle? Well, the areas that are normally sending blood to the left ventricle to be pumped out. And these are the lungs. Okay, so left heart failure will first produce problems in the lungs. The heart is unable to deal with all of the blood that is receiving, so the blood accumulates in the pulmonary circulation, producing increased hydrostatic pressure in the capillaries of the lungs. If the increase in hydrostatic pressure is mild, maybe nothing happens unless we actually start exercising. If the increase in hydrostatic pressure is important, the fluid will leak from the capillaries into the interstitial space in the lungs and even into the alveoli, producing pulmonary edema. So sometimes the ventricle that fails is the right ventricle. That is not so frequently. When the right ventricle fails itself alone, the problem will be in the systemic circulation. You're going to have increased jugular venous pressure. You're going to have hepatomegaly, lower leg edema, ascites, and the same process of edema in the dependent areas of the right side of the heart, which is the systemic circulation. Now, what normally happens in most patients is they start having a failure in the left side of the heart, and later they develop a failure in the right side of the heart. Okay, so you can say that the most common cause of right side or right heart failure is left heart failure. Okay, normally the right heart fails after the left heart has failed. Okay, and we use the term congestive heart failure for patients that have some symptoms of congestion. Okay, for example, breathlessness, abnormal sodium water retention, systemically resulting in edema. It can be lower leg edema, can be ascites, can be enlargement of several organs due to the accumulation of fluid. Yes? Uh-huh. But the congestion will occur in the area that is giving the return, or the dependent area. This is what we call the dependent area. Okay? The heart has to work, for example, the left ventricle with the blood that is coming from the lungs. I am receiving 500 milliliters, I have to send 500 milliliters. 500, 500. If I'm not working, 500, 100. 500, 100. 500, 100. 500, 100. What happens with this amount of money that I am gathering here because I don't spend this money? I can travel a lot with it. Yeah. It will accumulate in the place where it comes from, not in the place where it goes to. Okay? Yeah? Anywhere. Congestion. You can have congestion in the lungs, congestion in the liver, congestion in the stomach, congestion in the legs, congestion anywhere. Sometimes the manifestation of congestive heart failure is abdominal pain. Why? Because there is a congestion in the stomach, and congestion in the liver is compressing all of the abdominal viscerae and is producing pain in the abdomen. Congestion is increased blood or increased fluid in this case in any dependent area of the right or the left ventricle. Anything. We're going to study later the causes of heart failure. Okay? One cause can be a myocardial infarction. The heart is weak. One cause can be a rupture of a chordae tendina. So the valve starts failing. So even though the ventricle, the myocardium is okay, the blood escapes back because the valves are not working well. There's a regurgitation of blood. Sometimes there is a narrow valve, mitral or aortic valve. So the heart is pumping, but the blood can't go out, goes back. Anything that produces a retention of blood, okay, will produce a congestion and a heart failure because there is congestion behind and failure in front. Remember, failure is the inability to provide blood to the organs, and congestion is the blood is remaining in the dependent areas producing congestion and breathlessness and edema and all of these things. And this can be, or sometimes the failure, or what fails is the capacity of contracting. You have to imagine, for example, someone who has a weak heart, sometimes some drugs, sometimes a myocardial infarction, sometimes viral infections, for example, weaken the myocytes, the cardiomyocytes, and they don't contract very efficiently. So they receive blood very well, but they are unable to produce a strong contraction. But sometimes they contract well, but the walls are so thick that they don't have capacity to receive blood. And we call that diastolic failure. The heart doesn't dilate. Contracts well, but doesn't receive enough blood. What happens with the blood that is not receiving the heart stays in the circulation, pulmonary or systemic. Okay? So we call that systolic when there is a difficulty pumping, difficulty contracting, or diastolic dysfunction when there is a difficulty relaxing or receiving the blood. If there is a difficulty receiving blood, if during diastole the heart receives very little blood, what happens during tachycardia? Imagine someone is receiving, every diastole, they are receiving 200 milliliters of blood or less. During tachycardia, what happens? We are reducing the time of filling, the filling time of the heart. So the dysfunction will increase very importantly. We are going to see how people who have diastolic failure are very sensitive to tachycardia. Okay, not as much as people with systolic failure that don't have any problem in the relaxation. The contrary, they have a very relaxed heart that doesn't pump. Notice the data, epidemiologic data, okay? Almost 6 million people have a certain degree of heart failure in USA. 1 in 9 deaths had heart failure in 2029. Heart failure as a contributing cause. About half of the people who develop heart failure die within 5 years of the diagnosis. And this is the cost, estimated cost, almost $31 billion every year. So it's a very important disease. And let me tell you, once heart failure is established, there is not too much that we can do. Okay, sometimes the only thing you can do is change the heart. It's like when, for example, when you buy a new t-shirt, it's nice. And when you wash it like 5 times, it's good for nothing, just to clean the windows or to sleep. There's nothing you can do with that t-shirt. The same happens with the heart. Once it hypertrophies or once it dilates, there is nothing you can do. Change. Find a new heart. Okay? So the most important thing with heart failure is prevention. Prevention, 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 prevention. And then when you detect someone has a certain degree of heart failure, immediately refer this person to the cardiologist, because they are going to follow up this patient very carefully to decide when they need a heart transplant before the heart completely dilates or the heart completely hypertrophies and there is nothing to do. So there is nothing new here. The heart works every minute of our life. There is no moment when the heart rests, maybe only once in our life. Well, death is part of life, so only once the heart rate rests. The heart has to adapt to many different things, many different situations, exercise, stress, infections, different things. When we are children, does it very well. With age, the adaptive capacity decreases. Okay, something that we know. This age-dependent adaptive capacity declines, or decline is accelerated by different conditions. For example, if the heart has to be working against resistance, most of the time, it will get damaged earlier. Okay? For example, people with hypertension, or when the heart doesn't receive enough supply. And compare this to a person. If someone has to work under stress, this person has to retire earlier. Or if the person is not paid well, the person will look for another job or will quit completely. Or if the heart has to work too much or doesn't receive enough supply, for example, in coronary artery disease, the decline in the capacity for adaptation will occur earlier. And people will be at risk of premature death or different types of diseases. We are going to see that every type of heart failure, either systolic or diastolic, okay, will result in the same thing, an increase in the afterload at the end of the systole, okay? An increase in afterload at the end of the systole. There is something missing here. Well, there is something missing here, but we can continue without that. Okay. The heart, if the heart has to work against resistance, okay, that means that there is an increase in afterload. Afterload means the amount of the force that the heart has to do to pump the blood. Remember, there is a preload. That is the amount of blood that the heart receives, okay, from the venous return, stretching of the heart walls. Then the heart, when it has to pump, it will make a force and has to overcome a resistance. This resistance is done by the aortic valve, the gate, that is in the outlet of the left ventricle, and by the peripheral resistance in the arteries, in the arterial circulation. If there is an increase in afterload at the end of the systole, this increased pressure will slam the aortic valve to shut earlier, and this will cause a reduction in the stroke volume. Okay, so anytime the heart, there is an increase in peripheral resistance because of high blood pressure or any kind of obstruction in the aortic valve, okay, this will reduce the stroke volume. So any increase in afterload, remember afterload, say this is blood pressure, okay, will produce a reduction in the stroke volume. So in the amount of blood that goes out every pump, and of course in the amount of blood that goes out every minute, the cardiac output. Okay, this can be reduced either by high blood pressure or also by an stenosis or narrowing of the aortic valve. Well, there are some compensatory mechanisms, but today we are going to finish earlier because we have a very complicated day.